Good afternoon and welcome to today's IAC webinar, Novel Applications in Cardiac CT. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we monitor questions throughout the presentation, and we'll try to answer as many as possible during the Q&A period. On the left sidebar, please note the Polling tab. Today's webinar will feature one live poll question for our audience. Also on the left sidebar, please note the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, please click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASRT CE credit, you must be registered, logged into this webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now at this time, we would like to launch our poll question to get to know our audience today. Which of the following best describes the type of department you currently work in? A, outpatient radiology, B, outpatient cardiology, C, hospital, or D, other. And I'll give everyone a moment to answer. Okay, we have 43% outpatient cardiology, 39% hospital, 11% other, and 5% outpatient radiology. Thank you all very much for your answers. And now I would like to introduce today's guest presenters, Dr. Manish Motwani and Dr. Omar Khalique. Dr. Motwani is a cardiologist and physician scientist at Manchester Heart Institute in the UK. He specializes in non-invasive cardiac imaging, including cardiac CT, cardiac MRI, echocardiography, and advanced nuclear techniques. Dr. Khalique is the director of the Division of Cardiovascular Imaging at St. Francis Hospital and Catholic Health in Long Island, New York. He is a recognized expert and thought leader in the fields of multimodality cardiovascular imaging and structural heart imaging. Both are true experts in the field, and we are pleased to have them with us today. And with that said, I will now turn this webinar over to today's first speaker, Dr. Manish Motwani. Doctor?
Thank you very much for that introduction and for the invitation to be here. So my talk is going to focus on artificial intelligence and machine learning and plaque quantitation as some of the novel applications in cardiac CT. So you can see on this first slide here that what I've actually done is I've taken my presentation and uploaded that to DALL-E and just to get a summary image, and you can see DALL-E, which is a GPT aligned technology, has generated this image. So this is just to give you an idea or a taster of the technology that we are currently, the technology we currently have at our fingertips. So you can see a CT here, a heart, coronary plaque. It's even figured out that this is for the IAC. So this is really the sort of technology that is at our fingertips. So how does artificial intelligence, where does that fit in cardiovascular imaging? Well, actually, AI in cardiovascular imaging has a role to play in every aspect of the cardiovascular imaging workflow. It can certainly help in image acquisition in terms of speeding up image acquisition. There can be AI techniques behind undersampling techniques, and it can facilitate reconstruction of images and denoising. And once those images are acquired, it can certainly facilitate segmentation of the regions of interest and quantitative analysis within those regions of interest. That then allows us to extract deep amounts of data. And when you have all that much data, we need a technique to integrate all that data, which again, machine learning and AI techniques have a role in. And that integration of data can then lead us to be able to predict prognosis. And in some cases, these same techniques can assist us in diagnosis and decision making. So if we look at the literature or the way these fields are moving, we obviously know cardiac CT is a modality on the move, and there's an exponential increase in the numbers of scientific papers and publications that relate to this modality. And the same is true of AI, machine learning, and deep learning. These are two topics that are both on the ascent, and they come together with multiple applications and exciting technologies. And if you're interested in learning more about these in a deep dive, the FSCCT put together this series, which you can link to from here, which is still available to view. This is just, the top 10 papers from a year ago within this field. And you can see AI, machine learning in cardiovascular CT is a very exciting area. We see here papers that are showing how algorithms can be used to automatically score coronary calcium scores from non-cardiac CTs with no human input. We can see how plaque burdens are being used to predict ischemia. We can even see how radiomics and analysis of perivascular fats on coronary CT can be used to predict mortality. We can see how techniques can quantify visceral fat burdens and all sorts of things that you would not think possible and would not have the time or feasibility to do with human cognition or human segmentation of the data. So that's all very good and well, and exciting, but what is the reality on the ground? So when I have a cardiac CT, this is the process I have to go through. I get the images, I have to click in the software over and over. We can see here a plaque in the top left window, and you can see I'm zooming in. Then I will have to search through the menus in my software to find these crosshairs. I will put these crosshairs over the plaque. I will then move the images around a little bit. And you can see at the end of it in here, after zooming in, we've still got a stenosis that I'm saying is 50%. So after all that clicking and moving and zooming, I've still got a borderline significant stenosis. And it took a lot of time to get there. And, that's all very good and well when you have one plaque in a coronary CT, but the reality is our patients have many plaques. So we'll have to go through that same process of manipulation and clicking for each of these plaques to generate or to assess them in detail. So if you have 10 or 20 patients on a reading list, you can see how a human is going to struggle to get through all of those images. And at the end of it, your eyes are boggled and you don't know what's what. But, CT is a modality on the rise, and we're getting more and more patients referred. So this is an unsatisfactory situation. Coronary CT readers have had enough of clicking, scrolling, windowing, centerline editing, and double obliquing to just be able to read these images. So, like I say, this is an unacceptable problem. And when you have a problem, there are three solutions. You can either accept it, change it, or leave it. And I think this is an unacceptable situation that we have to change. And fortunately for us, we live in this era of all these new technologies, AI, machine learning, deep learning. And certainly in the last decade, there's been an incremental increase in the feasibility of these technologies to help us. And that's driven by massive changes in CPUs and computational power. And don't forget, of course, we use these technologies in our daily life. They help us with our Amazon predictions. They help us by telling us what we would like on Netflix. They help us manage our spam boxes, and they help us with photo recognition, face recognition. So we use all these technologies already in our daily life. So why on earth would we not use them in healthcare to facilitate the massive burden of patients and imaging that is currently our nemesis? So how do some of these technologies work? Well, they actually work pretty much like brains. So if you think about convolutional neural networks, what these networks or layers of algorithms are doing, if you train these algorithms on thousands and thousands of images, they take each image and they look at a first layer of the image. So here you have an algorithm that's been trained on lots and lots of animals, thousands and thousands of animals, and when it's given a new picture, it knows to look at a first layer to sort of get a feel for what sort of creature this may be, and then it knows to look at a second layer and then a third layer, and then it goes through many iterations of looking around this image to see what it can be. And that's pretty much how a brain works. And you can see what builds up is that when these algorithms are presented with a new image, they can then predict with some certainty the likelihood of what animal this image is. So here you can see it's likely to be a dog, and this is likely to be a frog. And this would have been thought to be sci-fi a few years ago, but it's actually pretty simple now. You can do this yourself with Google ML Vision. You can train an algorithm, in this case with several thousand pictures of Waldo, and then you can present it with a new image, and you can see it can pick out Waldo with this robotic arm in just a few seconds with 98% accuracy. So I challenge you to beat that, and you can instantly see how this form of image recognition and detail recognition could help a human reader with diagnosis and data extraction. And the beauty of machine learning is actually that the more data you give these algorithms, the greater the system performance. They get cleverer and cleverer and cleverer. And based on new data, they adjust up and down the algorithm weights to increase their accuracy and prediction. And the same cannot be said of humans. Humans have a learning curve, yes, to begin with. As they do more and more and more, they get better and better. But then they also get more and more fatigued and tired, and there's a limit to that learning curve. Not the same for machine learning. So that's the background, but what can these algorithms do? What do we have at our disposal at the moment? Can these algorithms actually segment plaque in the way that you saw me doing manually? And the answer is yes, they can. Here you can see a coronary with some calcified plaque. And here you can see an expert reader who has segmented out the calcification and the lumen. And here you see a deep learning algorithm from this research paper here. And you can see they're pretty much identical. And this deep learning algorithm has just taken 31 seconds to do this. And it would take significantly longer for a human. And they're indistinguishable. So really, this mundane task that we spend a lot of time being done could feasibly be done automatically. And when we think about just not the coronary plaques, if we think about segmenting all the cardiac chambers, to example, give us an LV volume, an RV volume, a left atrial volume, a myocardial volume, we have to segment out all the chambers of the heart. And here in green, you can see a human doing this. And here in red, you can see a deep learning algorithm from this paper here doing that. And this would take a human more than an hour per patient to segment all these chambers. But this can be done by deep learning algorithms in, as you see here, 13 seconds per patient. So that's no longer even a contest anymore. So yes, we can segment coronaries. Yes, we can segment cardiac chambers. We can segment our images. you may say big deal, but actually, if you add up the amount of time we spend segmenting structures on these images to be able to read them, if you can do what you were doing in 20 minutes and seconds, this actually adds up to 600 to 700 physician hours per year. So that's a big deal. That, a salary for a fellow, or significantly more time the clinician can be engaged in patients. If you still think, look, there's not really a case for this, and I'd rather do things manually and stay at this point in the evolution spectrum, let me try a different sort of argument. We're frequently presented all the time with patients and decision making. So let's look at these. So this is a 30-year-old male with atypical chest pain and no risk factors. They go on to have a coronary CTA. This is clearly low risk. We have a more elderly gentleman with typical chest pain and high cholesterol. They go on to have a coronary CT with 3 vessel disease. This is clearly high risk. So these sorts of decisions are not difficult for us. Those are easy. But what about the situation when you're presented with a middle-aged chap with atypical chest pain and high cholesterol? But what if their HDL is good? What if they're already on a statin? What if their calcium score is 40? What if their BMI is 38? What if they have a CT which shows non-obstructive coronary artery disease? What if it's mostly non-calcified? What if it's mixed calcified? What if the left main's involved? What if there's only 4 plaques or 15 plaques? What if the chest pain's 3 times a day? Or what if it's just one episode? What if they have normal blood pressure, no diabetes, never smoked? But what if they're South Asian? There's a lot of data here, and this is all beyond human cognition to be able to integrate all of these factors. So what we tend to do is ignore all of these and just focus on the first 3 that we assess: their age, their chest pain, and their cholesterol. And that does a disservice to the patient because we've not included all of this other data. And that's before we even consider weak classifiers, which are factors that we've not even considered. So how can we get around this? So this is a study from the CONFIRM registry. And what was done here is the coronary CTs, they were read, and every possible factor from the CT was extrapolated and recorded. So here we have, 40 coronary CTA factors: the distribution of plaque, the type of plaque, the location of plaque, the segment involvement score, the segment stenosis score, the degree of calcification, the cal score, lots and lots of factors, everything you could possibly read from a coronary CT. And then we've also integrated it in green with clinical factors such as traditional cardiovascular risk factors. And so we've got 50 or 60 factors here, and then we've used machine learning to integrate all of those into a single metric or machine learning score. And what happens when you integrate all these imaging factors with clinical data is you end up with being able to significantly predict mortality much better than if you just use clinical factors alone or if you just use the CT alone. So you can see here how machine learning is being used to integrate all of that data, both clinical imaging and clinical factors, in a capacity well beyond human cognition, to be able to predict a patient's individual personalized risk of mortality. But look, our CT images are getting better and better, and Dr. Khalique will come on to that with photon imaging. We're getting better scans, more detailed scans, but we are wasting all these pixels. Each scan has 300 million pixels. Look at the beauty of a plaque, really. There's all sorts of textures and different amounts of data in a single plaque, which we tend to ignore. We obsess about the stenosis. But how can we extract all of these features? Well, the answer is we develop new softwares that allow us to segment and quantify plaques. So many of you will be familiar with this. You can see based on threshold limits, you can segment out calcified plaque and non-calcified plaque, and your software can add all of this up. But the problem with all of this is that you do all of this and you end up with another 12 or 13 bits of data that you have no idea how to handle yourself or beyond human cognition to integrate into risk. So the answer again is machine learning to help integrate all of those new bits of data. And what happens when you do that is that you can end up with a risk metric that actually predicts ischemia as good as ammonia PET. So you can see here, you've got plaque features being integrated into a machine learning risk score that does a fair job compared to PET or predicting ischemia. And you can see how that works. So in this artery here, you've got a 60% chance of this being, ischemic. And that's basically very similar, or you end up with, you can put it together in models, a machine learning based CT FFR based on what I've just shown you. And you can see that that can be instantly comparable to a different way of doing things, which is computational fluid dynamic modeling. But this is using plaque burden and plaque features to generate a simulated CT FFR in a different way from something using fluid dynamics. So this is arguably a bit more elegant, and you can see that their diagnostic accuracies are very comparable for predicting ischemia. But, ischemia is well liked, and that's because we feel that it is able to risk stratify our patients and give some prognostic value. So is there anything that we can get from the CT that will do the same? And the answer is yes. And this comes down to the fact that you cannot have ischemia without plaque. Ischemia is actually a surrogate marker of plaque. So look, if we can use plaque quantification software, it only makes sense that we can get the same benefit of risk stratification that we get from ischemia testing from plaque quantitation software. And we know this from our most simple, crudest way of assessing plaque burden, calcium scoring, that the more plaque you have, the more adverse risk you're at. The risk is not the tip of the iceberg, is not the little bear, is not the ischemia. It's the massive big bad bear or plaque burden lurking in the background. That's the risk for our patients. So plaque quantitation and plaque quantification softwares clearly make sense and have a lot to offer. And we know that if you do quantify plaque with some of the technologies I've shown you, that plaque volume does predict mortality. There's a separation of these curves based on high levels of plaque volume. And the same is true for all types of plaque volume, whether it's total plaque volume, non-calcified plaque volume, low density non-calcified plaque volume. They all separate out in terms of cardiac mortality. It's quite simple. The more plaque you have, the more at risk you are. And we spend a lot of time qualitatively trying to identify adverse plaque features, whether it be spotty calcification, napkin rings, positive remodeling. And we might spend a lot of time umming and ahhing, looking at a particular plaque to decide whether we're going to call this a vulnerable plaque or a high-risk plaque. But what if we could do that with not just 1, 2, 3, or 4 features? What if we could do that with 4,000 features? What if we could look at every single plaque and look at every single voxel within this plaque and look at the radiomic features? So radiomics is a technology that looks at things the human eye can't see. It looks at how the individual voxels relate to each other, the grayscales within those voxels, the texture. So you end up analyzing your region of interest with 4,000 features rather than just 4. What's cooler than a million? A billion. The same applies. What's cooler than 4,000. So this is radiomics, being able to analyze at a voxel level stuff beyond the human eye. So just like you can't see dust mites, they can still harm you. Just like you can't see things visually in certain plaques, they can still harm you. But we now have the tools with radiomics and AI analysis to actually extract that data that we can't see and identify risk. And there's more beyond the coronaries that these technologies can help us in. We know that there are radiomic analysis signals in the perivascular fat. This is based upon the principle that if there's inflammation in this fat, it exhibits lower Hounsfield units, and the radiomic signature changes in this perivascular fat. And this measurement has also been shown to predict adverse risk. So what's happening currently in the field is that softwares and companies are putting together end-to-end solutions facilitated by AI that can take your images, segment and extract the coronaries, quantify the plaque, and integrate all that data for you into a colorful report that can be shared with the patient with an individual risk. So this is the state where we're at, and these are being FDA cleared. And it's not just one group that's doing that, it's other groups, several groups that are showing that you can quantify plaque, and these measures directly correlate with invasive measures of plaque. And as I've shown you, can predict adverse risk. So what does AI and plaque quantification software add? It adds stenosis, burden, type of plaque. It simulates ischemia and gives us personalized and predicted risk. This is true pixel power that these technologies are offering you. There must be pitfalls of plaque quantification software, and there is. Currently, there's no standardization. We have different vendors, different thresholds, different methods. The terminology has not been agreed by societal groups. We don't know whether we should be using total plaque or indexed plaque. We don't know how this performs across different KV spectra. How should the results be presented? Is this over-engineering? Ultimately, who pays? And there are pitfalls of AI itself and all that goes with that. This is what I mean by over-engineering. This is clearly, a very nasty plaque. Do we need all of this and all these numbers to tell us that? Whether it's a crocodile or an alligator, this is very dangerous. And we could have done that ourselves in a couple of seconds. Does this really add? And ultimately, if we're going to be presented with these sorts of images, we have to understand that data begets data. Are we going to spend a lot of time trying to figure out what all of these images mean rather than these images? So we have to be careful about just generating more and more data that we then can't handle. Very briefly, I've not talked about AI and report generation, but many of you will have played around with GPT, so you will now understand that this obviously seems feasible with natural language processing. You can understand how algorithms can pick out cats and keyboards and then begin to caption those together into a report. And here you see IBM Watson doing that for a PE that it's picked up. It's then tallied that to a caption, and you're halfway to a report. So, is this all sci-fi? Well, not really. We can train pigeons to read mammograms. This is from a PLOS One paper with very high accuracy. It's not beyond the stretch of imagination that these algorithms are going to become part of our daily practice. Images were not that much of a big deal. But are we out of a job? Not really. We're going to use AI to augment our reads, facilitate our reads, so that we can spend more time with this chair turned around, spent with our patient, rather than tapping away at the computer. So final cautions. AI is great, but it does lack context, and humans bring context. Clearly, this image is not a tiger. It's a dog against some rails in the sunlight. Just because I bought one toilet seat from Amazon does not mean I need to be bombarded with several adverts subsequently. How many really am I going to buy? So AI lacks context. Humans bring context. So to summarize, we have already accepted AI into our daily lives. AI, machine learning, and deep learning in CT can handle segmentation, quantitation, prediction, and a lot more. The gift of time, we should use this to do our menial tasks so that we as clinicians and physicians can spend more time with patients. Plaque quantitation just makes common sense. It adds personalized risk assessment, and the role of cardiac images is going to evolve more to data curators and contextualizers of the findings, and this will lead to more high engagement in patient care. And very finally, never underestimate technology. This was Thomas Watson from IBM in 1943. I think there's a world market for maybe 5 computers. So caution for those who are not believers in the scope and potential for this technology. Thank you very much. I look forward to your questions later.
Okay, hello everyone. Let me put mine up. So I always hate following Manish because his accent sounds so sophisticated. But now on top of that, I feel very inadequate as a human now after hearing all the machine learning. So I'm twice as upset with him. My talk is going to be on photon counting CT, which is a novel technology, which a few people have now. So at least I've been hearing about this for my whole career, photon counting, and when is it coming? And after many years, this was finally developed and released by Siemens in 2021, and more recently in the United States within the past 1 to 2 years. And we're lucky enough to get this technology recently. So what does photon counting CT mean? Well, there's a different type of detector that's being used now in addition to the photon counting feature. How does that compare to the traditional detector? So the traditional detector that we're used to is called a energy integrating detector. What does that mean? So we have a scintillator, which is an indirect X-ray converter. So the impacts of the radiation produces a scintillation light proportional to X-ray energy. And what does this mean? As all the signals are combined, right, we're not measuring each energy level, some of the information is lost, and what we get at the end is an energy-weighted accumulated signal. So we get more of an average signal of all of the energies being produced. And this also, an important part of this process is that it's a two-step process, a conversion of X-rays into light, into current. So that makes it more complex, and there is some information lost. Now, when we talk about photon counting CT, we're now using a semiconductor, which allows a direct X-ray conversion. The impacts produce a charge proportional to the X-ray energy. The individual impacts are measured, allowing for a measurement of energy information. So that's the photon counting. So we're measuring every individual energy. And this is a single-step process. So the individual signal of each photon is detected, and it's a direct conversion from X-rays into current. So what does that mean? The potential benefits. So smaller detector pixels, which allows high resolution imaging. Elimination of electronic noise. This helps us with obese patients and with low dose scans. Intrinsic spectral sensitivity. So that means that's the photon counting part. So dual energy has been around for a while, probably for the longest with Philips. But now what we have is the ability to further sort that out, some of which is in research applications, but will be gaining clinical use. And we get an equal energy contribution. So because because of those improved detectors, we're getting more of a uniform energy contribution, which allows less image noise, smoother images, and theoretically more diagnostic accuracy. And there are other vendors, of course, working on this. Siemens was the first to come out commercially. GE has been talking about it as well. And they're planning on using a different material, silicon. And this is just from their website, which you can read. So we were lucky to have the first dedicated cardiac photon counting system in the United States. And we started using this in January of this year. So we've had it for roughly 9 months now. And immediately within the first month, when people were not even that used to it yet, the reads of indeterminate segments for coronaries decreased from 18% to 11%, and that's further decreasing now. Now, what do all those technical things that I mentioned, what does that mean practically speaking? Well, one big thing which has happened is that we no longer really have a cutoff for calcium score for our coronary CTs. So this is the case with a calcium score of 900, but we've done double and triple that without issues. And what you see here are two types of images. So you see on the left-hand panel in the red writing that it's a 0.2 millimeter scan. So that's ultra high resolution mode. And you see a sharp kernel. So there the calcium is really well delineated. But even in the right-hand scan with the regular kernel, so more of a medium kernel, the calcium is very well outlined, and there's no trouble whatsoever, as you see in the short axis images, of really quantifying the lumen. Another big area for us has been stent imaging. So you see that here, there's another ultra high resolution CT. And what we can see is that there's a 0.2 millimeter reconstruction. That's the ultra high resolution. There's a medium to sharp kernel. But we can see each and every node of these stents, and these are two different vessels. And we're able to very accurately say that these stents have no stenosis and no plaque. Now, here's another case of multiple stents where we're using a sharp kernel, so BV68. Again, ultra high resolution. And you can see in the cross sections there that although there's probably a little bit of blooming, there's really not much. And in both the native segments and the coronary stents, we have a very good view of the intraluminal space, and we can clear these stents. And these ones are probably, I don't remember the exact diameters, but in the range of 3 millimeter stents. So kind of a medium-sized stents, and we've, I believe, done even one smaller than that. So we are a pretty complex coronary center. Many of our operators participate in complex interventions, and we do a lot of intracoronary imaging. So multiple stent cases are common, and also intravascular lithotripsy and things like that. So what we can see in this image is that these are multiple stents, and they're also overlapping in the area of the red bracket that I'm showing you. So what we see again is a very clear view of the lumen inside the stent. This is again a 0.2 millimeter slice thickness, ultra high resolution. And what we can also see in this image is actually the stent has been opposed against a lot of intraluminal calcium. So we can see the multiple stents, the layers of the stent, the nodes, and also the calcium, which is external to the stent as well. And we've really never been able to see to this degree of detail previously. Another issue which has been not solved, but at least made much better, is that there's always been this idea of using a sharp kernel to reduce the blooming, be able to see inside calcium and stents. But one of the flip sides of that is as you get your kernel to be sharper and sharper, you tend to get more image noise. Now that's somewhat counteracted by other iterative reconstruction techniques. But what you see here is that even in the BV68, which is quite a sharp kernel, our calcium is well delineated. We have a slight increase in image noise, but a very interpretable study, which allows us to both maximize the effects of the kernel while maintaining an adequate and acceptable level of image noise. So I showed you a lot of normal stents. So what about abnormal? So these are two different reconstructions from the same patient on the left, showing in-stent restenosis. So you see a very minor amount of in-stent restenosis, and this was a preoperative clearance case. And in the upper right of the left panel, you can see that there is some stenotic plaque there, but it's mild in-stent restenosis. And another thing we can see when we zoom up in this case, you see in the right-hand panel, is that perhaps new plaque formed or some plaque was missed in the original procedure. So we see this soft plaque on either end of that stent. And I just want to give you a comparison here. So the right-hand image is also from, a good scanner, but clearly the resolution and image quality is much, much better in the left-hand panel, which is from the photon counting CT. Another feature of this, because of the spectral features, is that we have the ability to, after the fact, remove calcium. So you can see in the image towards the right, third panel, where it says pure lumen. So what we've done here is we've actually artificially removed the calcium. And what that allows us to do is see just the lumen. And practically speaking, this is early on in the experience, but one thing it's been helpful with is comparing that luminal size to the reference vessel without that noise adjacent to it with the calcium. And you can see that since we don't see the calcium that well on the invasive angiography, that actually the pure lumen image correlates quite well to what we saw on the invasive. So what about structural? I think there's a clear superiority with the coronaries, but in the structural space, there have been some interesting uses. So this was a study where we were asked to do a low contrast volume TAVR CT, and this is the same exact patient. So on the left, you see a 70 kV monoenergetic recon, but of course, we know that we have the concept of the K-edge of iodine. So what we did was post hoc, reduced the kV, so we created a different monoenergetic recon to 40 kV, and it created an image which is just as bright as any high contrast study that you've seen. And here is the same patient. This is a Cine image from the same patient, and I don't think anybody would be able to tell that this was a 30 ml contrast CT. And this is just another image comparing. These are both good quality Cines from a TAVR case. But you can see on the left from the photon counting CT, with Siemens, it's a dual source. So the temporal resolution is better in general. So you can see it's a much smoother image. And then also we have a much higher degree of resolution and image quality, even compared to a different scan, which is also done on a high-end scanner. So another thing which this reduced blooming feature and ultra-high resolution imaging allows us to do is to better see leaflet thickening after TAVR, which is a big concern now with so many devices having been implanted, and particularly in younger patients. So these thickened areas, which can represent thrombus, tend to form very close to the stent frame at the edge. And this is the area where blooming can be the most problematic. But here it's given us an enhanced ability to see that. Now, valve degeneration is a big problem now. So many valves implanted, as I mentioned. And we think of valves as one big device, and maybe not in more detail than that. But one thing we can see here is a lot of detail demonstrating different portions of the frame. So you see at the blue dotted line, you can see the nodes without a skirt. So there's nothing in between the nodes. And then on the bottom part at the green line, you can see the nodes with the skirt. That's the dark area in between the nodes. And for planning of a redo TAVR, so putting a TAV in TAV, we see the native leaflets here, sorry, not the native leaflets, but the leaflets of the first TAVR, the index TAVR, which are pretty thin, but we can see them quite clearly. And what that helps us do is to plan our TAV and TAV and judge the risk of coronary obstruction by a sinus sequestration, which appears to be a risk in this patient that I'm showing you. So just other things, there's some research which is starting to be produced. This is a poster which was presented by one of our medical students, showing virtual non-contrast images. So he took the contrast image, reconstructed it at 3 millimeters, and artificially removed the contrast. And it shows an excellent correlation and a strong agreement with the true non-contrast image. So perhaps this is an area where the non-contrast image could be, the true non-contrast image could just be skipped in certain cases. So a couple slides I'll just show quickly before we end. So tissue characterization is a potential advantage of spectral and photon counting CT. These applications are still being explored. Manish showed a lot of nice slides on plaque analysis. This is another area where we have much more data now with the photon counting acquisition, and I'm sure will be explored with the artificial intelligence as well. Thank you.
Okay, thank you very much, Dr. Khalique. And at this time, we will begin the Q&A session. From IAC, I would like to introduce Nancy Davis, Director of Accreditation for CT, and Maria Costello, Director of Accreditation for Nuclear PET. Nancy and Maria will assist with the Q&A session today. Nancy, would you like to start us off?
I would. So, first of all, great presentations and a lot of interesting information. And we have quite a few good questions. We'll start with how do these applications assure there are not built-in program bias for patient populations, resulting in over or underscoring of results? So, first of all, great.
So from an AI point of view, that is a very good question. It is all about training on diverse populations in multiple numbers. So to be clear, when AI algorithms are being developed, we're talking about thousands and thousands, tens of thousands, 50,000, 100,000 of patients in terms of training for robust algorithms. And that's very different from predictive risk scores, previously by other methods. But it is a good point, and it does require us as in our field to develop databases of well segmented images with ground truth from human experts that can then develop these algorithms. And we must make sure that they're representative across all societies, cultures, gender, to make sure that these algorithms are accurate with what they are then presented with. And it is true, I'm not sure if this is what the question was leading to, that currently that is not the case. They are often developed on databases, mainly in the US or China, from a number of research institutes, but not globally representative. So it's a good question, and that is one of the pitfalls at present.
Thank you, Dr. Motwani. Also, we have another question regarding the AI and post-processing. And the question is this method better or equal, in your opinion, to nuclear medicine cardiolite stress testing?
That's another good question. So I'm not aware of a direct at scale comparison of plaque burden based ischemia risk stratification versus nuclear imaging. I think that's what the question is. As I referred to in the presentation, there are a few studies at smaller numbers, 100, 200, that use the nuclear as the reference standard and show that the plaque burden method is pretty good with AUCs of over 0.8. But those are the sorts of studies that need to be done to bring the field with us to show this is an equivalent method of predicting stress, similar to what you've seen with FFRCT when that was introduced. You had initial studies that showed it worked, and then it's gone out into mainstream. People are using it. People have become familiar with it. People have done very large studies and found it to be, in some cases, as good as conventional stress modalities. But the same needs to happen with these plaque burden AI based technologies and softwares.
Excellent. And what are your thoughts on the accuracy and application of newer technology on the market with regards to plaque quantification?
I think it's very early days. It's certainly not something that, although these solutions are there, I think the field definitely needs to get a feel for this, what it is adding. But before we say, this is the new definitive gold standard way of assessing ischemia or whatever endpoint you take. But what I hope I alluded to is that what these tools are doing is they are extracting as much as possible from these images that everyone's worked very hard to develop and get better and better. To date, our obsession with stenosis has wasted all this additional data. I mean, Omar showed some beautiful images characterizing plaque, and not just in the coronaries. Everything else in the images now becomes available to you, looking at myocardial tissue characterization and the rest of it. So part of our responsibility in this field is to not waste that data, use it and develop these technologies to extract that data from the images. And then the clinicians amongst us will see what's useful and what's not, and hopefully those studies will be done.
Excellent. And I think this question is for Dr. Khalique. Are there any practical drawbacks, in your opinion, for photon counting CT?
I don't think particularly for photon counting CT there are drawbacks, but there are a lot of other things related to it which don't necessarily have to do with the technology. For example, the Siemens is not a volume scanner, so you still have to do a step and shoot or retrospective mode where you can get misregistration artifacts. And that just has to do with the way things have been developed. They've not focused on wide detectors. They focused on speed and now photon counting, whereas others have focused on wide detectors first and then may make it to photon counting. There's also an expense issue there, where to develop a wide detector photon counting system is very, very expensive and currently cost prohibitive, I think, from what I know. The other drawback with photon counting and also high resolution imaging is related to what Manish mentioned. There's so much data now that we don't know what to do with, and the more slices and more pixels you have, the more storage space you need. So there's a big issue on computing power and storage space.
Excellent. And a follow-up question to that is regarding the photon CT, how did you manage to convince senior leadership in the investment? And what was the ROI when compared to traditional CT or dual energy CT?
So so for us at least, I don't know which country that question is from, but in the US, the ROI for CT, the margins are very slim, as many people know. So our how we convince leadership, we're lucky enough to be in a cardiac hospital with a very high coronary PCI volume. A big part of it was getting the buy-in from the interventional cardiologists. This was really something that would not prevent them from doing what they need to do, but allow them to do what they needed to do better. So we had that support. The other thing was that we have been involved in research and continue to be, where CT is really a pre-planning procedure for not only structural, which everybody knows, but also for coronary interventions. The other thing, a big part of the push was also for ER patients. So ER doctors love coronary CT. We've been bolstered by the 2021 guidelines that, yes, it is a class 1 indication. And with this new scanner, it's been much, much easier to rule people out, definitively rule in or rule out. And that saves the hospital's costs with lengths of stay for observation patients and things like that. So I think from the financial standpoint, the ER part is a huge piece of it, getting patients quickly in through the chest pain pathway and being able to discharge them quickly.
And just a couple more questions here. One is, and I think this is probably for both of you, these novel applications, in your opinion, do you think over time that they are going to increase the expense of evaluating heart disease or decrease it overall in healthcare?
I'll chip in. So I think on an individual basis, the answer is they'll probably increase because you're applying new tools, new applications, new technologies, and the capital expenditure that was mentioned. But on a population basis, in terms of identifying patients earlier, identifying more patients with non-obstructive coronary heart disease that can be subjected to primary prevention medications. If you factor all that in, I would hope, based on the data to date of what coronary CT has done in terms of reducing mortality when it's routinely applied, that as a population over a period of time, it would be cost efficient and indeed save money.
Yeah, I would agree with that. I think it's a little hard to show right now, but if you just take a simple example of catching something early where you can treat with a medication to prevent that costs a few bucks versus at the stage where somebody has a big MI and then has to get stents and things, which costs the system tens of thousands of dollars. I think on a population level, there's a pretty clear argument.
And then I think just one more question, which actually, when I was at FSCCT, I found some of the studies really fascinating. But can you speak to how the new recommendations and the new technology may affect traffic in the cath lab, like how it will affect the amount of catheterizations that are being performed, and will it replace in some portion those procedures?
Yeah, so I can answer that a little bit from the US perspective. So that it is sometimes a tough argument financially. Of course, the best thing for the patient is to avoid any invasive testing. Sometimes the business people say, well, why would you get rid of a diagnostic cath, which earns however many of thousands of dollars? But the counter argument is that if you have enough overall volume, that you're instead replacing those diagnostic cases only with the ones who truly need stents, or at least increasing the percentage. And that's been shown in some data, including that of heart flow, that actually the percentage of cases where you're doing an intervention, which is a higher revenue procedure, you can do just as much volume, if not more, and then you can target those patients who really need that invasive therapy.
Okay, so sorry, did you want to say something, Dr. Motwani?
No, I was just going to give the perspective from the UK healthcare system, which is not revenue based, but looking at the images from the photon counting imaging, we would be looking to save money on every test, and we would want to avoid doing the more expensive investigations. So I could only see that saving us money.
Excellent. So I think that's about all the time we have for questions, but the questions that weren't answered, we will try to get answers out to the participants. And thank you for all your answers.
Okay, thank you. And thanks again, everyone. And a very special thank you to Dr. Motwani and Dr. Khalique for their presentation today. IAC also wishes to thank Dr. Renee Bullock-Palmer for her efforts in planning and recruiting the presenters to help bring this webinar to fruition. Also, in early 2024, please be sure to save the date for the next live webinar in the series, featuring Dr. Palmer and Dr. Jameson Borg, taking place on Friday, January the 12th at 1 p.m. Eastern. More details on that coming soon. To receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Novel Applications in Cardiac CT. Beneath this title, you will click Review Event. On the left, select the Evaluations tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.